Hello, I'm Jonathan Hartens, and today I'm going to tell you why we need more male minority mental health clinicians. When we talk about cultural competency in healthcare, most think it's about training clinicians to better understand their patients. But cultural competency is not only about training, it's also about who's in the room providing care. Today, I'd like to tell you about the current minority male provider gap and how it affects cultural competency, patient engagement, and treatment outcomes across many healthcare systems, including the Department of Veterans Affairs, the Department of Corrections, and Community Behavioral Health. Let's begin with the most fundamental point about mental health treatment. The foundation of effective treatment is trust between a patient and his or her provider. Yet currently, there is a significant demographic mismatch that inhibits that trust. Did you know 80% of the mental health workforce is white and 60% is female? Yet the healthcare systems with the highest mental health needs are racially diverse and male. This mismatch negatively impacts trust, communication, and outcomes. The underlying issue is referred to as therapeutic discordance. This occurs when there is a mismatch between a patient and clinician in identity, culture, communication style, or lived experience. Research shows when a patient feels a sense of shared identity or shared understanding by their provider, trust increases, self-disclosure improves, and the therapeutic alliance strengthens. But when discordance is present, patients, especially men of color, are more likely to distrust the process, disengage early, and withdraw emotionally. For veterans, incarcerated individuals, and trauma survivors, these relational dynamics often determine if treatment succeeds or fails. As you're listening, I'm sure you're starting to get an idea of why it's so important we have more male minority mental health clinicians. Well, as you're thinking, here's some more precise reasons why. When a veteran or justice involved man of color walks into a therapy space, he immediately asks, does this person understand where I come from? Do they get me? Do they even know what I've gone through? The data show that minority men, particularly Black and Asian men, have the lowest level of engagement in mental health services of any group. In the VHA and correctional systems, untreated trauma disproportionately affects men of color, leading to relapse and recidivism. So across many settings, such as veteran services, corrections, and community care, the disconnect between largely female provider staff and largely male patient populations creates predictable relational dynamics that hinder treatment. Regretfully, several systemic contributors got us here. One contributor is structural misalignment. This occurs from the establishment of a workforce that does not resemble the population it serves. The outcome is that men of color don't view therapy as relevant or trustworthy. It also discourages men and minorities from pursuing the mental health profession, leaving vacant job positions to be filled by white women. And so the cycle continues. A second issue is pipeline shrinkage. For those minority males interested in mental health careers, the financial barriers, lack of mentorship, and unpaid practicum requirements push minority men out of the training pipeline. Shrinking progresses as the number of those that start in the career pipeline decreases as they move forward in that pipeline. Another factor that's part of this is that Black and Hispanic candidates pass the respective licensing exams at significantly lower rates compared to white candidates due to cultural and socioeconomic factors embedded in the exam design. And when these three factors are woven together, we're left with therapy being seen as mostly as a feminine or verbal profession that conflicts with men's natural means of problem solving. Fortunately, there are several promising solutions. Some pipeline programs, partnering with historically black colleges and universities, Hispanic schools and institutions, and tribal colleges, draw more men of color into the field. This also creates mentorship and financial support early before students fall out of the pipeline. Another focus is expanding paid practicum hours to reduce the financial barriers on minority trainees. Another heavy focus currently is licensure reform to help ensure exams measure competence rather than test-taking skill tied to socioeconomic background. Recruiting service members is another very popular pipeline method that helps create rapport between a provider and patient when they've shared prior experiences. These are just a few of several strategies being tried across the country. Thankfully, several national agencies are participating in a call to action. The American Psych Association is expanding fellowships, diversity initiatives, and research around training equity. These are positive steps, but national policy alone is not enough. Real change happens locally within local hospitals, institutional systems, and community programs. It requires leadership that is intentional, persistent, and collaborative. National resources and local leadership is what will ultimately transform the workforce. With commitment, transformation is possible. So I'll summarize by saying that the shortage of minority male mental health clinicians is far more than a diversity issue. It requires us to restructure systems with intention of restoring communities. It includes addressing multiple barriers in workforce development that directly shapes outcomes for the men who rely most on mental health services. Healing happens in relationships, and relationships are strongest when patients feel understood culturally and experientially. This is why we need more male minority mental health clinicians. It is essential for proving outcomes and restoring trust in underserved communities. Thank you for your attention.